we will start by talking to the panel about what is Advair exactly. We'll kind of describe what that is and see what it's used for and get the discussion started there.
Madam Chairman, just to go on record, I object to the use of slides because the other part of the group did not have the ability or was encouraged to bring up pretty slides to show the adverse effects. I'm not saying we stop, I just want to go on record.
Yes. So noted. Dr. Branch.
You're not the chairwoman.
I have a chair.
Yeah, and
I
I'm a
will say
woman,
that I-
so she's a chairwoman. Come on.
Thank you.
Let's put two and two together here, Doctor.
I will let everyone know that I was under the impression it would be a very informal discussion, and when Dr. Branch and I discussed it, we decided, oh, probably no slides were necessary. These slides I will allow. They are not really on one side or the other. They are more informational. This is what Advair is. This is what the medications in it do. That is the extent of that, and the rest will be discussion only.
That's on my line. Basically, I just wanted, because some people have never seen it, never given it, never been exposed to what Advair is, and it just comes in a discus form. There is an inhaler form, but mainly we just use the discus, and that's what it looks like. It does come in 3 different doses. The most say the higher dose is not recommended, but 250 and 50 is usually the average dose. But I just wanted to show you the inside of how these work for the patient.
What is this?
This.
Is it delivered? Is it inhaled?
Inhale.
Yes, it's inhaled.
Oh, okay.
That's what, if you look at this, the medication is in this little foil area here.
Okay.
And it's just like a little dot of medication. So that when I take this, and what I'll do is open it up like that, there's a place here for the mouth. And when you're using this with a patient, and I think one of the biggest things with Advair, and when these are given, they're given out, and you get an order, people go to pharmacy, pick them up, and they're not really given the education they need on how to do these. And that's probably the biggest thing that I see with this. And Advair, once you get it exposed and you take it, it should always be kept sideways. You start doing this and that medicine drops off of there. So it needs to be kept sideways, brought up to the mouth, and then nice big inhalation. They get their lips kind of big seal around it, big inhalation, so that they get that powder down into the lungs evenly. And that's kind of what this slide is, just showing you the inner workings of it. And I thought it was kind of interesting to actually see for myself how it works. If the patient misses a dose and they do it, go around, and then think, oh, I didn't do that, and do it again, then you get some free dust of the medication in there. And I don't know if you take this around and if you want to try it, because this one's had like 4 doses left in it, and I just kind of shook it through. I did clean it real good. But you can hear it, and it's kind of gritty, so the medication just kind of floats around in there. So that's why it's really important for the patient to know how to use it. Keep it straight over, inhale it, so that they get all the medicine, and that it's not around in there. And the biggest thing I'm going to say with this, it is not in any way a rescue inhaler. I see these ordered. We have patients that are only on this. I just did a PFT on a lady this week that came in, only on, she's on Symbicort, has no rescue inhaler at all. That's where we get into problems. This is not meant for any rescue. If they have asthma or COPD, any kind of inflammation going on, they need a rescue inhaler. And that's probably my biggest thing with all of them, with this, is they really need a rescue inhaler.
I would like to thank Deb for supporting the con group here.
No, that's not common, that's education. That's just purely an education. But has a steroid and it has long-acting beta agonist, which this kind of does two sides. I always try to tell people that the steroids are kind of coming from the back side of you, and where the salbutamol that's in it is coming from the inside, so it's kind of working at both angles of the lungs. But the biggest thing is the long-acting beta agonist is, that's just it, it's long-acting. It's there to help, it's preventative. It doesn't do anything to take care of immediate problems with the lungs, and that's the biggest thing. It's all preventative. That's why I put that in there, because that's the biggest thing I do in teaching at the bedside with patients is, you know, when they have these, when to look for problems, what types of problems to look for, because they absolutely need to have.
Jeff, not to interrupt you too much, but you said that was albuterol, but that's not albuterol.
No, not albuterol. Salbutamol. These are the two that are in it, and what I just kind of went over, salbutamol goes by relaxing the muscles in the airways, but it's preventative to keep you from having it. And the steroid's gonna help keep out the infection. And that's my biggest thing is this, with one other thing, a spacer. When you send this home without a spacer, or an order for a spacer, medicine comes out at 90 miles an hour, impacts the back of the throat, and has to go through the system systemically. If I have a spacer, I can slow that medicine down, it goes in and makes that curve at the back of the throat, goes down into the lungs, and I can give that medication evenly into the lungs. That's why it's important to always use a spacer with an MDI. And I think my goal is to get all of Clinton County on inhalers with spacers involved.
Isn't like the goal really of Advair, one of the theories behind it, to lessen your use
It
of
should, yes,
inhalant,
yes.
basically?
Hopefully you have less exacerbations.
Right.
And
Well, it's-
that's where the preventative,
It's got two indications, one is for asthma and one is
for COPD, yes.
So, you know, as asthma, it's your control. As for COPD, it's supposed to relieve symptoms and give you some longer term benefits too. In terms of your comment about how do you use it, this dinosaur will say, that when it first came out, the drug reps used to tell us, hold it like a hamburger and suck it like a milkshake. So I think it's a nice still about keeping it flavor. There have been recent studies to say that for asthma and hospitalizations and control, patients who are on Advair, and I think it was Advair specifically, I don't think it was a combination long-acting beta-adrenergic and a non-absorbed steroid. But Advair in particular had, those who were using Advair had the least hospitalizations for exacerbation of asthma. There's been some concerns about sudden death from it. They will just drop dead on it. That's why the caution that you should never use a salmeterol alone for asthma, but you may use salmeterol alone for COPD. Now, how many patients with COPD also have an asthmatic component? So it's one of those.
We're gonna discuss more of that Dr. Dominic just brought up in just a little bit here. But we're gonna move on to what is Advair used for, how does it work in the lungs, and I think Dr. Beaver has some answers for us with that, and anybody else is welcome to join in.
So part of my portion of this is to address the pathophysiology of medicine. For that I felt that slides were necessary, so my apologies to Dr. Branch. I tried to not make them not too pretty, so they won't sway people unjustly. This is obviously just a picture of Advair discus As we already discussed, Advair is a combination medication. It combines a corticosteroid with a long-acting beta-2 agonist, which is referred to as a LABA. So from here on, when I say LABA, I'm referring to the salmeterol in medicine. The corticosteroid, as was already discussed, is fluticasone, and the LABA in Advair is salmeterol. The role of the corticosteroid in the treatment of asthma and COPD is to inhibit the steps in the cascade of inflammatory response. So initially, it was felt that asthma in particular was strictly a disease of bronchodilation. Around 20 years ago, people came up with the theory that it was actually an inflammatory response. And that was around the time that steroids started to play a significant role. Inside the airway of the lungs, there are multiple allergens that cause inflammation of the airways, and so the steroid helps to decrease that. So the major effect of the corticosteroids is to inhibit the synthesis of many inflammatory proteins through suppression of the genes that encode them. As I was researching this, I found it was very interesting to find out that this actually happens at a genetic level, where in the cells it turns off genetic expression of the inflammatory process. As I say there, it works at the DNA level to decrease the gene expression. This results in reduced bronchial hyperresponsiveness, prevention of late asthmatic response, and enhanced lung function. This refers to asthma. Now in COPD, there is a benefit from the corticosteroid, but what they found is it's not as significant as it is in asthma. It does in COPD decrease exacerbations, modestly slows the progression of respiratory symptoms, but has no impact on lung function and mortality. The role of the LABA portion of Advair is to activate the beta-2 receptors on bronchial smooth muscle, which allows muscle to relax, resulting in dilation of the airway. So a LABA is essentially like albuterol. It's just long-acting. In the case of salmeterol, it's twice a day. To get the equivalent effect in albuterol, you would need to do it something like 4 times a day. This effect on the smooth muscle is achieved by binding to the beta-2 receptor on the smooth muscle. And what everyone needs to know is that albuterol, salmeterol are all very similar to epinephrine, but what they have done is modified the chemical so that it only affects the beta-2 receptor, so that you don't get all the other adverse effects that you would get if you're giving someone epinephrine. They believe that the way it relaxes that smooth muscle is that it affects the intracellular calcium concentrations in the smooth muscle of the airway. They've discovered since then that the LABA has more effects than just relaxing the smooth muscles. It affects mast cells, mediator releases, which the mast cell is responsible for what causes hives, what causes a lot of allergic reactions, so that causes the swelling in the airway. It also decreases or inhibits neutrophils and eosinophils. Eosinophils are your main allergic reaction white blood cells. And it also increases mucociliary transport, so that helps the mucus and cilia move faster to get rid of the inflammatory materials out of the lungs. And then it affects vascular tone and edema formation in the bronchioles, so it actually decreases the edema. And then this is a picture of your multiple agents that we use in the airway and how they affect different areas. So you can see the corticosteroids have their effect on the mast cells, cytokines, and inflammatory mediators. And then you can see the beta agonist working directly on the smooth muscle receptors to affect the inside of the airway. So Advair is provided in different strengths, and it's expressed as micrograms of fluticasone or over micrograms of salmeterol. Advair initially came out as only a purple discus, but later they did release an inhaler, a hydrofluoroalkene inhaler. So Advair is provided for the treatment of asthma in patients 4 years and older, and for the treatment of COPD, that's the discus. It's available in the following strengths that you see up there: 100/50, 250/50, or 500/50. It is dosed as one inhalation 2 times a day. The inhaler is approved for the treatment of asthma in patients 12 years and older. It is not approved for the treatment of COPD. It is available in those strengths up there, 45 over 21, 115 over 21, 230 over 21. It is dosed as 2 puffs 2 times a day. The Advair drug will go off patent in 2016, and an interesting fact is not only is the drug combination a patent, but the device itself, the discus, is a patent. And the current cost of that discus is $400 a month. In
Retail, or what some people call street value.
so GSK is a very
You could
smart.
sell your office samples.
Got a street value.
GSK is a very smart company, so they knew that this was going off patent, and so they have developed a new drug to replace it. It's called, and a new device to replace it. It's called the Brio Ellipta. And unlike the discus, it's once a day instead of twice a day, and that is the Brio Ellipta right there.
So that's before you,
And to be even more slick, they have it charged, or the cost at $300 a month, so that they will try to take business away from the discus before it goes to generic. And the medications in that device are those up there. I'm not going to try to pronounce them. I'll let you just.
I will point out that in your picture there, Will, if you could go up a little bit back to the picture.
This one?
Yeah, that's fluticasone. And Pill-Antor.
No.
So,
Huh.
this may be something.
Oh,
that-
you know what? I bet the. I'm not sure. No, it wasn't autocorrect. It was definitely I copied it down from the website, so it was a copy. They are coming out, and I'm wondering if I confused. They are coming out with.
There's another one.
Yeah, they have an anticholinergic. That's probably the anticholinergic. So,
That's the,
so I'm sorry. That's probably fluticasone and formoterol.
Don,
Is that called Brio too? But it's got a different secondary name?
It's called Ellipta, but it's got a different name.
Okay,
So
it's the other way around.
the Ellipta is the device, and yeah.
Well, what we are gonna do, what are the known side effects of Advair?
There are a lot of them. If you, as I did some searching on this through different areas, the common side effects kept coming up about the same with all the different websites that I went to. So I did a little internet scrounging and found out all kinds of things that I didn't know, whether or not they're legitimate sites and legitimate research. That remains to be seen, but just, you know, there's like 4 pages of actual possible side effects from the inhaler itself. I kind of focus more on adverse reactions.
let me point out, those are dose independent. They all have the same percentages depending, no matter what, low dose or high dose. Is that right?
I think so, yes, yes. Under adverse reactions, the big ones are headache and upper respiratory tract infections, pharyngitis, things to do with CNS system issues, dizziness, perceived pain, and not actual pain. Some GI, some people get sick from it, nausea, vomiting, diarrhea. I suspect that's where they're probably swallowing more of it than they're actually inhaling, which this is something that's not easy. I mean, a lot of this evolves around technique, because you can't kind of suck the stuff out of it and wind up swallowing it rather than inhaling it. Throat irritations, and that's a good point. One of the side effects is candida infections that can happen, and generally we recommend with the people that use almost any kind of inhaler, when you're done with it, to rinse your mouth out and spit that out. To try and keep those things going. Again, lesser side effects, cardiovascular problems, migraines, different skin irritations. Some of the longer term things I think you see with the steroids, mood changes, Adderall dose packs or Deltazone dose packs, I've heard people say, well, they get mean, or they get angry, or they're less cooperative than they ever were. I've heard that from the drugstore days when people would come back and tell me, I don't want any more of those because those caused a lot of fights in my family. So, I mean, that type of thing, but those are long-term steroid effects, which again brings up the point that when you take people off of Advair, for instance, generally it's a good idea to do a step-down program, either cut the dose, use a smaller inhaler, or cut it back to once a day for a while and then kind of back them out, rather than take them off cold turkey. And again, that's an individualized thing. Some people are affected more by that steroid drop off than others. Not everybody's affected either.
Supposedly it's an absorption.
That's not true. It is well documented.
There is some absorption.
No, it is, the higher dose is equivalent to taking 10 milligrams of prednisone a day. Is that not right, Don?
I've never heard of this.
It's right, it's in the
Comparing the
physician desk reference,
hypo-
easy to access.
Polemic pituitary axis.
No, there is, it's documented about disruption of hypothalamic pituitary adrenal axis. It's well documented in there.
I haven't seen the dosage, but I have seen where it has said that the higher dose, having the 500, is you get what you need out of the 250, that the 500 really isn't necessary to have.
It is.
But I haven't seen that dose
It is.
reference.
And so a 250 twice a day is equivalent to 5 milligrams of prednisone a day. Don, is that not enough to cause some kind of disruption if it's absorbed like that?
Long term.
Yes, long term.
Short term,
Yes, but
You know.
that effect has been documented now to 4 weeks after starting Advair. The early data was like, well, let's look at 2 weeks, let's look at 3 weeks and report that data. They failed to report what happened after 4 weeks from it.
The thing though with that is, you give Advair when you have somebody when their asthma or COPD is controlled, and what you're wanting to do is keep it controlled. So if they're out of control, you don't do it because, you know, a lot of times when they come in the hospital and we have them on steroids, we don't have that going because you're adding to it. But you're getting it topically to the lungs, which is different than systemically when it goes through your body. And you're putting a low dose there topically so that you get less of the side effects that you get with taking oral. My husband was on steroids and 80 milligrams for 15 years, and he backed down to, 20, and I mean, he was on for years and years. So I have a lot of experience with somebody being steroid dependent, and and opposed to having somebody on even 5 for a low dose when they have severe asthma, because that's the first thing we reach for. And sometimes in some of these asthmatics, that's the only way you're gonna keep, or severe COPD, that's the only way you're gonna keep them from getting their inflammation back.
Yeah,
And-
let me point what you're saying, back to what you say, that it's not absorbed, or there's a limitation of absorption. That's like saying, well, the oxygen's only kept in the lungs and it doesn't go through the circulatory system. That isn't how it happens. You put something into the lungs, it will get absorbed. That's all. How
Well,
much?
yeah,
It depends, and
how
I've given
much?
you the equivalent.
Yes.
500 micrograms of fluticasone twice a day is equivalent to being on 10 milligrams of prednisone.
And in that same thing, when you're bringing up oxygen and talking about the absorption, there is so much different with the oxygen being absorbed at a tissue level, and there's so many things with the dissociation curve and all those things that make a difference, and that will alter the fact of somebody having oxygen in their system, how much is really binding or not, if they have sickle cell,
Let's-
anemia,
let's-
those types of
Let's
things.
go back to the steroids here. But now, first of all, we haven't even mentioned the long-acting beta agonists. Don, tell me if I'm wrong. Has that not been linked to, paradoxically, an increase in asthmatic deaths in children and adolescents?
yeah, sudden death is one of those things that's in the
But
literature.
it has not been proven to be
But I don't know what
statistically
the-
significant.
I don't know what the link
Oh, I
is.
disagree with that.
and
I'm
that-
sorry.
that
I'm
is-
sorry. They had to release the federal government came down and found this information out. They were forced to release a black box warning that this could happen, and it is linked to it. I'm sorry, that
They-
data
they
you
have.
may be
Black
quoting
box
is old.
warning for-
They have, and you're
I
absolutely
do
right.
not believe the
that-
data I'm quoting is old, it's directly out of up to date. It's
But,
about as up to date as you can get. I'd like to hear some less emotional arguments, more fact-based arguments.
All right, let's go.
That-
So,
but that's where it went back to the education piece of it, because it's just like, there are so many people that go and they have an Advair at home, and that's all they're doing, because they think, oh, I mean, this lady that I did this week with a PFT, she thinks, she took her Advair or her Symbicort, and she thinks, oh, it's made such a world of difference. You give that lady to take that twice a day, and if you don't send her home with a rescue inhaler, she's gonna think, oh, well, maybe I need to do another dose of this. And that's where, if we don't back it up with education to do, rescue inhalers, you are going to see more asthma deaths, because if you send them home without a rescue inhaler and the proper instructions on how to use it and how to recognize when they are in trouble, that's where people get into trouble, and that's where people die. I mean, I've been doing this for 30 years. That's where people die
And
with
it's-
asthma.
It's well known,
And-
you get no effects from Advert for 30 minutes after you
Advair? Oh,
Yes,
yeah.
okay.
Yeah, it's not-
But if I
it's
do an
not a rescue
albuterol,
inhaler.
if I do an
It's a control,
albuterol
it's not a-
treatment or an MDI, I have effects within 2 minutes of giving it. And then within 15 minutes, I have full, so between 2 and 5 minutes, I have effect that I'm doing on the lungs, and
We
that's
do-
why
We do not
we
disagree
need
with
to
you.
have
Now,
it.
Will wants some facts. Okay, let's do some facts. Well, let's start with the simple observations. A lot of people on Advair today. My observation has been, in some circumstances over the years, it's just been given out like candy. Here you go, you got this, take this right there. The instructions in it say you must wean down to the lowest dose possible, but most people don't ever go to that direction. I agree. If you're gonna get off Advair, you need to wean it off. And I'm gonna go on a personal level here back to that. My wife was told by a pulmonologist, oh, just stop it. Just stop it. Now, let's go back to some of the other effects let's finish up some facts.
So that was for asthma, right? That was for asthma.
Asthma.
Now I'm out for COPD.
Not
In
COPD,
COPD, there's only one dose approved for COPD, and that's the 5250 dose. I'm not sure about when you say the MDI, the HFA is not approved for COPD, it's only for asthma. Is that correct?
The last time data was available for the sales of Advair was in 2009. At that point, it was a $7 billion industry. $7 billion. It's $419 per discus now in 2015. And as in 2010, it was $200 for one of those. In 2012, GlaxoSmithKline, who makes Advair, paid out $1.043 billion to the federal government in a settlement case, because they had shown that over the years they had influenced physicians in prescribing it, either by paying them off or bringing other enticements to them to prescribe Advair for all kinds of reasons that weren't warranted at all based upon the medication from there. So, other side effects: osteoporosis, glaucoma, pneumonia.
I didn't wanna bore you with the list.
Oh no, upper respiratory tract infections account for 27% of the complications of Advair. Basically, you're taking a steroid, you will become immunosuppressed. It isn't just a local effect. Okay? Now, let's go to the GI symptoms. One of the things I've noticed is that a lot of people may not have diarrhea, and you're right, probably because they bring it in, but even now in inhaling, they actually suffer from the opposite, constipation. But it's not listed as a side effect. They have abdominal pain and constipation. After they move their bowels, they feel better from there. In researching on the effect of steroids affect actually the thyroid. They affect the thyroid in such that it doesn't make goiter, but it prevents the release of those thyroid hormones, T3 and T4, so that people can actually have normal metabolism. It doesn't affect the TSH. But if you measure, they're not euthyroid anymore. You get them off the steroids, then it releases that part. We know hypothyroidism, because it's, in effect, what you're producing does cause constipation. People who are hypothyroid have a complaint of constipation all the time. So there are other things on here that are not directly pinpointed out, but there are other effects that have. Now let's talk to the most serious one, hypothalamic adrenal axis, pituitary adrenal axis disruption. Now, it's reported as fairly low, but it is significant enough that this warning has been put out. The CNS effects of steroids, fluticasone, which is the synthetic steroid, include malaise, insomnia, even fatigue. And it's even worse that when you try to get off of it, if your adrenals have been suppressed. And if it's not a well-recognized that this occurs, then it's easy enough to just turn your head and just ignore the symptoms because they're fairly nondescript. They really are. But if you take someone and you measure their AM cortisol level, then you give a cosentropin stimulation test, you'll find out that they have adrenal suppression or adrenal insufficiency, secondary adrenal insufficiency. Secondary because the aldosterone works fine. So what happens is that part of the adrenal cortex does not function properly. And I have seen it. I've witnessed it in my own wife as she tried to get off Advair. She saturated fine. Her heart rate was not elevated. But she had this feeling of dread that she was suffocating the whole time. And this went on for 3-4 months before I was able to put her, the pulmonologist called in a low dose Advair, and she's been okay from there. Did I test her adrenals? I had an endocrinologist test them. Yes, she has adrenal insufficiency. She is dependent upon that steroid dose that she gets. It's too easy to turn her head and say, it doesn't happen. It does happen. So how long has she been on Advair? 10 years. 10 years ago, a doctor says, oh, here you go, take this. 250, I'm just guess she was lucky she didn't throw her on the 500 microgram dose from there. 250, take this. She's been on it for 10 years. She's trying to get off of it now. She's still back on the Advair. So Advair is a multi-billion-dollar a year industry. All right? It is now what I consider the perfect drug. Why is it perfect? Well, first of all, it alleviates your symptoms. Second of all, you get hooked on it. You can't get off. 4 weeks it takes to affect the adrenal, the adrenals. And the third is it's expensive. Let's be honest about it. You may get your insurance company pays a lot of it, but maybe you're paying $50 or $100 for every month for this, and the insurance company's kicking in their point from there. So I don't know if she'll ever get her adrenals back. I'll be honest with you. And I think you have to start looking at this in people now who have been on Advair for long term. You've got to say, do they have adrenal suppression? All right. After having gone on that soapbox, because I know it's real, I still maintain it's the perfect drug. It makes a lot of money. Once people are on it, they have a hard time getting off, and it is expensive.
I think your wife's experience is one anecdote. I've had a patient who had bad asthma, was on Advair, and went through a lot of different things, and she finally stopped the Advair from going to another pulmonologist and stuff, and she's been feeling a lot better. That's a second anecdote. But I think that to cast the medicine as bad throughout for everybody, I think it's a mistake. And I think that my patients who have asthma and COPD, when they go to their pulmonologist, the concerns that you've expressed are never brought up. I mean, I just have, there's, every drug has, the list of side effects that you can get. I love the ones where they say diarrhea and constipation, all right? I love them, because is it, how much of it is placebo, how much of it is what? I think your concerns are real. My own understanding of all inhaled steroids is they are minimally or only partially absorbed. I've not heard the 5 milligram prednisone dose equivalent of Advair 250 Advair 5. A lot of my patients go on and off of it depending upon how they feel when they're having a good month. Or if the spring and the fall are their asthma times, and most of the other time they do fine, they'll stop it. I can't say I have horrible they feel when they're, going off medication and stuff. I think there's just a lot of anecdote out there to try to differentiate how common is it. And I think your experience with a family member is real, and it really happened. With all of these new genomic medicine things, maybe, Catherine had some sort of, she was the person with this kind of metabolism that really sucks onto every one of those corticosome molecules and sends them straight to the systemic circulation, where most people don't. Okay, it's just hard to say. I think to cast the whole medicine in the black cape that you've done, plus it's been an enormously effective medicine, and as I said before I heard your concerns about it, I mean, that is the medicine that keeps people out of the hospital with asthma. It is the one. That's it. Everybody else is in the hospital a hell of a lot more with their breathing, poor asthma control, feeling sick a lot. I have a hard time accepting that it's the devil.
We cannot stick our head in the sand. It's a steroid. As someone once told me, a good friend I used to work with at MIT, it is the worst, it's the best, worst drug ever. We have to accept the fact it is a steroid, it has effects systemically, and there's plenty of literature out there and research that's done that shows this. Even fluticasone has been attributed to, they can equate it to exactly how many, because they've done the research on it, how many milligrams of prednisone based upon the average absorption through the pulmonary system into the bloodstream. I agree. It's been a wonder drug, but I think we have to sit back and say, well, wait a minute. Every drug someone's been on for a long time is going to have side effects, and we need to be aware of what those are. And honestly, again, Kathleen, the pulmonologist, just stop taking it. It doesn't work that way. It has to be weaned. I don't think we're aware enough that we put people on this, we need to wean them down to the lowest dose possible so they can get through.
One reason I feel skeptical about making broad stroke statements about that is these medicines have been studied extensively in children. And one kind of evidence that it's affecting the adrenal hypothalamic pituitary axis is growth stunting. And there is some, but it's really a very, very small amount, and ain't nothing close to what systemic steroids do. So I just have some high skepticism about how broadly this affects our patients.
Well, I bring it up that I suspect Kathleen will be on steroids the rest of her life because she will always have adrenal insufficiency. I don't think she's going to be able. And by the way, the recovery from adrenal insufficiency caused by inhaled steroids, minimum 1 year. If you've been on it for a year, it's a year to get off. And then I don't think they know after you've been on it for a year how long it's going to take you to get off. So think about that. You're on Advair, you try to get off, you go through a year of working to try to get off. Again, that just reiterates what I say. It's the perfect drug. You get started on it, it's hard to get off. And that's something I think it needs to be with people who prescribe this or give it out need to be aware about. That it's not just something that's going to take care of your symptoms or help you get through a certain rough period, but you'll be able to drop it afterwards. How many people undergo this adrenal insufficiency? We don't really know. The literature's out there that documents that this does occur. And to sit there and say, well, if it's a low, then, we'll accept that risk. But those people who that happens to, it's very significant, very severe for them.
I'm assuming your wife has asthma.
Yes.
We don't wanna put her whole
No, she's
information out here,
She's
but,
never smoked a day in her life.
but how is her asthma now?
And on the 100, it's okay.
It's okay, she's controlled.
Yeah.
So if she wasn't on that, I mean, people die every day still of asthma. Just because you have asthma doesn't mean you don't have a risk of dying. We may not see it that often here, but they die every day of asthma. So do you take a risk? And that's where patients have to be informed in the education, and they have to be the ones to help make that decision. They hand out the literature, these are the warnings. Anytime you have one side effect when they're doing studies, doesn't it have to be put, even if they have one person that's
But that-
diarrhea, they have to put
That
those in
puts you
there.
in side effect if you,
Right, Right, but, you
And
know,
if it's constipation and diarrhea and all these conflicting
So-
things,
so
well,
they-
it makes it confusing.
Yeah.
You know, fatigue,
And the other-
agitation,
and the
because of
other
the psychiatric
medications.
effects. You know, a lot of these things, they get really hard to sort out.
and the other
Yeah,
medications
so-
she's probably on, I'm not gonna throw out
None.
my list of medications,
None.
but, you know, you add a few together and you get all those that you're taking, can make a difference, but, you know, you have to weigh out the risks of, do you wanna do something that is semi, what I'm gonna call benign in treatment, and try to keep asthma that could potentially, the wrong flare up at the wrong time or the wrong thing you get a hold of could kill you. Do you wanna go and, you know, try to treat that at a low level and try to keep under control, or do you let it go and keep having flare-ups and down and
Well-
up and down? And that's a hard choice for
And then,
patients to have to make.
what you need then is to establish what kind of asthma do these people have. Do they have mild, moderate, or severe asthma? That's not being done. I see Advair just being given out. When she finally went to see the pulmonologist, she has mild asthma. She could have done well with the rescue inhaler and been good from there. However, she got thrown immediately onto 250 micrograms of Advair. So where's the medicine there? I mean, someone should have been aware that she needed to be tested, needed to figure out how severe it is.
So she never used just plain pill.
She had a rescue inhaler, she never used it.
So, Steve, I think you've done a good job of pointing out that Advair has a lot of side effects, as do most medications.
Yeah.
And I did have a question. I came into this discussion thinking we were going to be discussing the risk factors of LABAs. I didn't know we were going to be discussing the risk factors of steroids. You focused on Advair. Are you concerned about the other inhaled steroids? I mean, there's a large class of them. It's the first line medicine for asthmatics in terms of if they fail PRN use of albuterol, they have to go to something that's a preventative medicine, and usually a inhaled steroid is that medicine.
Yeah, actually, your comment about your wife's treatment and her asthma was diagnosed and these medicines were out there. People are saying now she should have been tried only on an inhaled steroid first and not given the LABA. And the concern about sudden death has been pretty much exclusively the long-acting beta-adrenergic, not the.
No, and we said that only applies to the pediatric and adolescent population. So if she was long out of that before she was ever prescribed.
But you know, if, and supposedly modern day ideal medical care, if someone comes to me who's 24 years old and has asthma, is poorly controlled, has not seen a doctor for a long time, and is pretty much green and doesn't control her, an inhaled corticosteroid is considered number one. I mean, this is asthma gold standard, it's right there. And that's why I just have a hard time accepting that it's just this horrible, terrible medicine, and that it affects a large number of people. I'm not saying it didn't affect Kathleen. I am saying that, you know, I just have a hard time accepting that it affects a large number of people. My one anecdotal patient who took it and stopped it and felt great, you know, just was, I mean, she's on practically nothing. You know, I'm glad about that too. I mean, there's a lot of things we don't know about how medicines work, and they all have their side effects.
But, and Joe, it's one thing when medicine has a side effect, but when someone's on medicine for long term, and you're talking about someone starting at 24 on inhaled steroids,
Yeah.
you're gonna have to assume they're gonna be on for 40 years or more. We just need to stop for a minute and say, what's gonna happen in 10 years? What's gonna happen in 5 years?
Well, actually, you know,
Sure.
that's applicable to every medicine. You know, if you're on a high blood pressure medicine and your blood pressure is absolutely controlled, it's a good time to back off.
My son
You
was
know?
15 when he went on Advair for asthma, and all three of my kids have had asthma. My last one was the worst, and ended up finding out that he has a lot of allergies that also play into it. But he was on Advair for a couple of years, but he had a respiratory therapist at a mom that didn't keep him on it all the time. I watched him once he got better. You know, he was then taken off once he was better controlled, and we also did what was his triggers. We had him tested, allergy tests, finds out cat's killing. You know, if he's around a cat, he's, you know, horrible. He's allergic to grass. He's allergic to lots of things.
We did, I just
But-
said, he's lucky
so-
to have you as a mom.
So,
Let's be honest
we
about
have to be, you know, and that's where I keep saying back, I don't think we can educate the families and the, you know, parents and the, people enough on what they need to look for at home, because we have to be our own best, teachers.
There's a concept of medical literacy, and some people have higher levels of medical literacy, other people have lower levels of medical literacy, and you're always struggling in that milieu. And where is a person starting from, and how far along the spectrum can we get them, so that they're, you know, using their medications appropriately, not stopping it inappropriately, you know, and things like that. That applies to everything that we do.
Right, but we also have to inform the medical community, look, these things have side effects, and they do affect patients from there. And you can't just say, stop taking it like that. You've got to be aware of that. Now, let me give you another example, and this affects Robert and I. People have been on Advair for long term. Let's say they're on the 500. It's equivalent to 10 milligrams of prednisone a day, and they need to have surgery. We're going to have to give them steroids, a stress dose steroids. That is recommended in the literature, that if you're on a high dose inhaled steroid, and you're going to have a surgery, even emergency surgery, you have to assume they have adrenal insufficiency, and you need to give them a stress dose of injected steroids. Did you know that?
No, I did not.
Yeah.
I mean, is
No,
this,
I
is this
did.
something that's spoken about among your colleagues before
No,
you came here,
I,
or?
you know, no, it's not well known in the literature.
Well, we've done that for people who take it orally, I mean, take prednisone.
Oh, of course,
50
no, that's
milligrams
totally
a day
different,
for
but, you know, when
all my
I,
life.
but if
And
you,
we've done that here.
but I think the point
But I
that,
don't know if we've done it for anyone.
that Steve is trying to make is, you know, you inhale anything, you're gonna get absorption. I mean, you know, how many times have you given epi down the tube with an IV? It's absorbed, like it's given IV. So there may be a difference. I don't know what coefficients, I don't know how it is.
It is absorbed, but not like the IV, because you double or triple the dose. I mean,
Right,
so-
okay,
But it's still
but
absorbed.
it's still absorbed.
I don't
And-
think
And-
anybody here argues that it's not. It's a known side effect of inhaled
Well,
steroids. It's a
according to
risk factor.
what, I bet if you asked any anesthesiologist, said, well, what do you think about Advair? Well, it's not absorbed, so why do I have to worry about it? Well, it is absorbed, and they came out, and when the first drug came out, they said it wasn't absorbed. I know that for a fact. I remember listening to people talk about it.
And that was
So
a big,
I
that was a big
think,
selling point.
yeah, and all I think is, you have to understand, when you're dealing with these kind of things, and you're manipulating whatever therapeutic regime you have, when, you know, long-term effect, you've taken somebody off it, you have to look and make sure they're doing okay, that maybe they're not adrenally suppressed. I think that's the whole point, and that's his whole point is, look, you know, we maybe have been sold sort of a bill of goods that this really wasn't bad, but in some certain cases, it can be deleterious, and I think that's what you have to realize.
And Joe, in your response about these things being tested, yeah, but they cut off the testing at a certain time. And what they do is they miss the next level as it goes on with the Advair. About, like I said, it was 4 weeks, but they had stopped the testing when they were checking adrenal suppression.
You know, the literature on children, and children are on inhaled steroids all the time. What I call non-absorbable or minimally absorbed, it ain't the same as taking prednisone pills or getting IV cyclophosphamide. But when they look at their growth trajectories, they are impaired a little bit, but not like systemic steroids. And the amount is, most doctors who, and we're all, and you know, the medical people here, let's face it, in resuscitation, ABC, B is number 2, you gotta breathe.
Yeah,
And, you know,
I'm not
and
disagreeing.
if someone has their activities curtailed, we're always, making compromises and trying to decide about whether somebody should have a surgery or not. You know, what's the advantages, disadvantages, benefits, side effects? So you're doing that with everything you do. As, I think, inhaled corticosteroids have a proven, documented, excellent track record as a asthma control. And I just can't accept that they're some sort of evil medicine that we need to get people off of, because there ain't nothing else out there anyway. There There ain't nothing else out there.
All right, so if you had someone who came in and they never tried Ventolin, would you put them straight on Advair?
Same thing, say that again?
They had asthma, young person, never had a rescue inhaler their whole life. And you had no other documentation, would you put them straight on Advair?
No.
Yeah, exactly, but I think we have seen that that's occurred more often than not. So part of this was to inform that, look, there are side effects here, we should look at alternatives to start with first, before jumping to the Advair, and the Advair should be reserved for those people who have moderate to severe asthma, and that is what's going to keep them going. And you accept, you tell them, we accept that there are risks involved in this, and these are going to be the side effects, but there's really nothing else we have now, until the next thing comes down the
You know,
line.
I guess the other thing I'll say is, if things are as bad as you say they are for many people, okay, and they were definitely bad for your relative, let's call it, how come it's not in the gold guidelines? How come it's not in all these, things that are trying to tell us how to take really good care of our patients? I don't see it there.
Well, part of what.
Maybe it will be.
is that
Maybe it
it's
will be.
not much in the literature, but there are studies that have shown where they've documented it, it just hasn't been disseminated or well-known enough, or enough information gotten out. Because we're at the point now, because when did Advair come out, 2005, 3?
2000.
No, it was 2002, maybe. It wasn't FDA approved until later.
It's 2001 or 2002.
Yeah. So we're now at the 10+ years where we're starting to see these side effects come up here. We're beginning to finally understand them. So we just need to be aware that these things are going to have
See,
long-term effects.
I disagree with you because inhaled steroids have been around for a long, long time before Advair. Long before Advair.
So
You
why?
know, that was, betamethasone
Yeah.
has been an inhaled steroid for, probably 10 years before that.
And what were the
And that's
most-
where the original studies on, children and their growth trajectories came
We
from.
aerosolized it.
And
Some of it was aerosol, some of it was puffer.
And was
I
that,
started
remember what
off
that
in
best
was that the
Israeli.
problem? Was that the problem? It had to be aerosolized?
We aerosolized it, yes.
Okay, so you had an
Beclomethasone, we
extra
started
step
off-
of difficulty in delivering it, but now all of a sudden
But
you
it did
eliminate
such a
that.
good job topically on those kids, then they started coming up with the
We had
inhalers with it,
inhalers.
because, originally, because
Beclovan was one of the original.
I was given, in '85, given
Vanciril and Beclovan,
beclomethasone, yes.
those were the
Yes.
betamethasone.
So Don, what happened to them?
Huh?
What happened?
They still do.
It's not called Q-Bar. It's not called
Bypass
Q-Bar.
by,
All the newer ones,
Yeah.
with seemingly less side effects.
was seen, yeah, okay, but so there were side effects.
Always.
So people
There
knew,
were steroids.
so there was side
Yeah,
effects, but
mild.
we act like that Advair has no side effects at all,
I think
or
everything is.
very mild compared to that, but we're starting to find out, no, it's not.
I'd like to just give one perspective here, which is that all medicines have side effects, surgeries have side effects. In the realm of serious side effects, this isn't huge. In fact, in 2007, the largest cause of accidental death became prescription opiate overdose. So if you want to look at something that causes a lot of problems, we need to look at opiate prescriptions, and that would probably be the number one thing that you prescribe. I know it's probably the number one thing I prescribe in New York. And there are other bigger fish to fry besides Advair.
Well, I agree. Now, mine are limited. You get one prescription, maybe two if you're lucky, and that's it. I'm not treating chronic pain. But I'd like to disagree. Surgery doesn't always cause side effects.
No.
Robert, do my surgeries cause side effects? Absolutely not. Not mine.
Speaking of surgery, we have to go.
It is
Yeah.
a few minutes after 1. Thank you all for coming. It was very lively and an educational discussion. Thank you all very much.
Yeah. So was